Today we are going to learn something about Hallux valgus. I am Dr. Azhar and I bring greetings from the north. Shakespeare once said, "What's in a name? A rose by any other name would smell as sweet." You must have heard the name Bunyan, which is interchangeably used along with Hallux valgus. Well, the origin of this word is controversial. Some of the authors believe that it's a Greek word that means turnips because the bony bump that appears on the side of the foot of a patient of Hallux valgus appears red and swollen like that of a turnip. So the prevalence of Hallux valgus deformity in adult population, it is surprisingly around 23% in the adult age group between the ages of 18 to 65 years, while it increases from 23% to 35.7% among those who are more than 65 years of age. So what are the clinical features with which a patient of Hallux valgus will come to your clinic? Well, most of them would be asymptomatic. The patients who would be symptomatic, the most common chief complaint would be difficulty in wearing a shoe. Some of the patient, the next common complaint would be pain over the medial eminence, and young females would come to your clinic with cosmetic concerns. Then because of the abnormal biomechanics, the patient is unable to bear weight on the first ray, so abnormal weight bearing occurs on the other rays, leading to pain on the plantar aspect of the metatarsal head. This is called as transfer metatarsalgia. Then because of the abnormal biomechanics of the foot, there are development of calluses and corns. So what is the pathology? The exact pathology of Hallux valgus is complex. It is multifactorial, and in short, we don't know what causes Hallux valgus. Although family history is present in around 68% of the patients, we haven't been able to identify or isolate a gene that is a causative factor for Hallux valgus. Although we have seen conditions like hyperlaxity, inflammatory conditions like rheumatoid arthritis and gout, neuromuscular conditions like cerebral palsy, Down syndrome and Marfan syndrome been associated with it. Because it is 3 to 4 times more common in females than in males, some extrinsic or acquired causes have also been attributed to its pathology, that is related to shoe wear. Wearing a tight-fitting, narrow-pointed shoe with a high heel in females have been attributed to a causative factor for development of Hallux valgus. This is an anatomical diagram showing the plantar surface of the foot. Here we see a strong group of strong muscle, that is the adductor hallucis, the transverse head, and the oblique head on the lateral side of the metatarsophalangeal joint. And on the medial side we have the abductor hallucis. You see here two sesamoid bone. This will be the fibular sesamoid and this will be the tibial sesamoid that is lying on either side of an intersesamoid ridge called as the crista. So this is a well-balanced metatarsophalangeal joint. Now this is one of the most famous diagrams that we have in our books, and to understand the pathology we have to understand this diagram. Here you can see that the abductor hallucis muscle, which lies medially, is slightly plantar to the flexion extension plane of the metatarsophalangeal joint. Now when Hallux valgus happens, there is lateral deviation of the great toe, valgus of the metatarsophalangeal joint, and varus of the first metatarsal joint. As a result of that, once the angle goes more than 35 degrees or 30 degrees, this abductor hallucis muscle moves more plantarwards. Once it moves more plantarwards, the adductor hallucis remains unopposed except for the medial capsule, which becomes attenuated and stretched out. Now also you can see the sesamoid, the tibial sesamoid, it subluxates laterally. While subluxating laterally, it abuts against the crista and flattens it out, while as the fibular sesamoid comes to lie in the first web space. Now because of this subluxation of the sesamoids laterally and the plantar movement of the abductor hallucis, the movements of flexor hallucis longus, the flexor hallucis brevis, and extensor hallucis longus all contribute to exaggerating this deformity. So what is the essential lesion for development of hallux valgus? Well, it's asking the same question like, which came first, the hen or the egg? There are two essential lesions that the authors attribute, metatarsus primus varus, which is, most of the authors believe that it is a very important factor in adolescents, while as in adult group, in the adult patient, most of the authors believe that it is lateral deviation of the grade 2 and medial angulation of the first metatarsal. So once we have a patient of hallux valgus in a clinic, we need to do a lot of assessments. First of all, we have to see whether the patient is symptomatic or asymptomatic. If the patient is symptomatic and painful, we need to know whether the cause of the pain is extrinsic or intrinsic. The causes of extrinsic pain are due to deformity and bunion irritation, while as in intrinsic pain, the reason could be because of joint incongruence, because of degeneration of the joint, because of some synovitis or metatarsophalangeal joints or sesamoid joints, or because of bunion, and because of transfer metatarsalgia. So a lot of factors need to be taken into account before we go into making a plan or managing these hallux valgus patients. We need to know the age of the patient. We need to see whether the first tarsometatarsal joint is stable or unstable. We have to rule out any flat foot in them. We have to see whether the deformity is correctable or stiff. We need to rule out associated infections and inflammation. We have to do a silver skull test to rule out tendinoachilles tightness. We also have to rule out previous surgeries and recurrence from there, and also we have to look for hyperlaxity. Now we have to look for systemic factors like rheumatoid arthritis, diabetes mellitus, osteoporosis. We have to look for associated lesser toe deformities. We have to look what is the we have to know what is the occupation of the patient. We have to know the neurostatus of the foot, what is the status of the medial dorsal sensory nerve. We have to look for other foot and ankle pathologies and deformities, midfoot deformities, the daily activity status of the patient, and the subtalar joint pathologies. While we do that, we need to know some x-rays that we need to take of the patients with hallux valgus. They would be anteroposterior weight bearing, lateral weight bearing, and sesamoid weight bearing. This is the way we take sesamoid views in our patients. Now what we do with these x-rays, we have to draw some angles, we have to look for joint congruency, we have to look for sesamoid positioning, we have to look for arthritis in the tarsometatarsal joint and the metatarsophalangeal joints. We have to look for the overall shape of the foot. So this is a patient with hallux valgus, and you can see the joint is congruent, while here it's a severe case of hallux valgus with the joint being non-congruent. The sesamoid views that we took, we can grade them depending upon the lateral subluxation of the tibial sesamoid. If they are placed on the medial side of a line drawn on the crista, then we call it grade 0 or normal. This is the normal position of the sesamoid. Once it deviates laterally, there is a lateral subluxation of tibial sesamoid less than 25% of it. We call it grade 1 or mild subluxation. If there is more than 50% of 25 to 50% of subluxation of the tibial sesamoid laterally, we call it moderate or grade 2. Once there is more than 75% to 100% subluxation of the tibial sesamoid laterally, we call it the severe or the grade 3 subluxation. So till now, you would be very confused about a lot of information going into a head, and you would be scratching your head by this time. Okay, so in order to simplify this presentation, you have to ask a minimum of 4 questions before you proceed with any sort of patient with hallux valgus. The first question you need to ask is there any metatarsophalangeal joint arthritis? Is there any hypermobility of the first ray? Is the metatarsophalangeal joint congruent? And the last question will be, what is the severity of this deformity? So we'll try to answer these questions one by one. So in order to see whether the metatarsophalangeal joint is arthritic or not, what we can do is we can take an x-ray and you can see there is arthritic changes in the metatarsophalangeal joint. and clinically we can do it by the axial grinding test. It is similar to that the one that we do for carpometacarpal joint. We hold the great toe and actually load the great toe. While doing that, we do a grinding maneuver. If this maneuver is painful for the patient, and for that matter any range of motion on the metatarsophalangeal joint, if it is painful, we have to clinically we can suspect metatarsophalangeal joint arthritis, which can be confirmed on a radiograph. So the next question that we asked was whether there is hypermobility of the first ray. That we can rule out by doing a root test. Here with one hand we hold the first ray, and with the other hand we stabilize the rest of the foot. Then we rock the first ray up and down dorsally and plantally and look for the excursion of movements. The normal excursion of movement will be 5 mm dorsally and 5 mm plantally. So that combined excursion of movement of the first ray would be 1 centimeter. So any excursion of movement more than 1 centimeter combined or more than 5 millimeter dorsally or 5 millimeter plantally would indicate a hypermobility. Why it is important to know that whether this hypermobility is there or not, because any sort of surgery in such patient is going to fail and it is going to have a recurrence. So the treatment of choice in any patient with hypermobility would be a LAPIDUS for the tarsometatarsal fusion. So the next question that we are going to ask in our patient is that whether the metatarsophalangeal joint is congruent or not. So here you can see the metatarsophalangeal joint, most of the articular surface of the metatarsal head. This is not congruent with the base of the proximal phalanx. On this X-ray, there is hallux valgus, but the joint is congruent. So this is how we draw the lines or angles in a case of hallux valgus. So what we do is we need to take 3 points on the shaft of the metatarsal, and we take the center points and we draw a line connecting the center points of these. We draw a line along the 3 points, so we get the anatomical axis or the long axis of the metatarsal shaft. Similarly, we have the long axis of the proximal phalanx and that of the second metatarsal. So the first angle that we draw is hallux valgus angle. This angle is nothing but the angle between the first metatarsal and the proximal phalanx. The normal values should be less than 15 degrees, and if the angle goes more than up, so depending upon the angles, we can have mild 15 to 30 degrees, 30 to 40 will be moderate, and severe will be more than 40 degrees. The second angle that we need to calculate is the intermetatarsal angle. The intermetatarsal angle is the angle between the long axis of the first metatarsal and the second metatarsal. This angle is called as the intermetatarsal angle, and normally it is less than 10 degrees. So the values more than 10 degrees will be high. Mild intermetatarsal angle will be between 10 to 13 degrees. Then 14 to 20 degrees will be a moderate, and severe would be more than 20 degrees for the intermetatarsal angle. The distal metatarsal articular angle is one of the most confusing angles that you will come across in hallux valgus. This is nothing but the angle which the articular slope of the metatarsal head makes with a perpendicular to the long axis of the first metatarsal. It is called as the distal metatarsal articular angle. Normally it is less than 10 degrees. Then we have the hallux interphalangeus angle. This angle is the angle between the proximal phalanx and the distal phalanx. Again, it should be less than 10 degrees. So now the third question that we had asked, what is the severity of the deformity? And depending upon that, the classification given by Coughlin and Robinson, we can group them into mild hallux valgus, moderate hallux valgus, and severe hallux valgus. So if the hallux valgus angle is between 15 to 19, it's mild. So the intermetatarsal angle should also fall between 9 to 13, while as the subluxation of sesamoid is less than 50%. In moderate cases, the hallux valgus angle is between 20 to 40 degrees, and the intermetatarsal angle is between 14 to 20 degrees, and the subluxation of sesamoid is somewhere between 50 to 75. In severe cases, the hallux valgus angle goes beyond 40 degrees, the intermetatarsal angle goes beyond 20 degrees, and the subluxation of sesamoid goes more than 75 degrees. So the treatment for And the non-operative treatment for hallux valgus have a very limited benefit. A lot of options are there online, and a lot of toe spacers and the bunion splints are available, but they have a limited role. What we can suggest to the patient would be wearing shoes with wide toe box. Ask the ladies not to wear heels or narrow shoes. We can ask them to go for physiotherapy, where we can do Achilles tendon strengthening physiotherapy and some exercises. So once we go to the books and we see that there are more than 130 operations that have been recommended for hallux valgus, it indicates that no single operation is perfect and none is going to address all the cases. So once you read about all the surgeries in the book, you become confused, like going to a supermarket and you don't know what to buy because of so many options that is present in front of you. So with more than 130 surgeries which have been recommended for the treatment of hallux valgus, it's practical to describe only a few. So what are the surgical principles while dealing with a case of hallux valgus? So what we have to do is we have to remove the bunion and correct all the angles that we have previously discussed. The hallux valgus angle, the intermetatarsal angle, the hallux interphalangeus angle, and we have to maintain the distal metatarsal articular angle, and also we have to restore the joint congruence. This is the surgical principle. This is a paper in JBJS that was published in 2018. The authors looked for the unfavorable outcomes following surgical treatment of hallux valgus deformity. Here they saw that if we do not restore the hallux valgus angle, it is associated with deformity recurrence. And intermetatarsal angle, if not restored, it is related to post-op patient dissatisfaction. So again, coming back to the surgical principle, what we have to avoid is plantar dissection of because the nutrient artery to the metatarsal head has a dominant plantar supply. So plantar dissection should not be done in the treatment of hallux valgus cases. Otherwise, there is risk of development of avascular necrosis of the metatarsal head. Also, we have to preserve the medial dorsal cutaneous nerve in our surgical approach. The dissection should be meticulous, and we need to isolate and protect this nerve during our surgical dissection. The other surgical principles are that we have to release the lateral tight structures, which are the adductor hallucis, the lateral capsule, the transverse metatarsal ligament, and the medial sesamoid ligament. So we have to release the adductor heads. We have the transverse and the oblique head, while as we also have to cut the transverse metatarsal ligament. This is the soft tissue release that we do on the lateral side. Then we have to relocate the sesamoids under the head of the first metatarsal. That is very important. Once we do that, we release the tight structures, and we tend to relocate the subluxated sesamoid under the head of the first metatarsal. So going to the medial side, what we have to do is we have to excise this medial eminence. We have to stabilize and debulk the medial metatarsophalangeal joint capsule with capsulorrhaphy. So on the medial side, which is stretched out and bulky, the capsule, we need to do something like here, something like a capsulorrhaphy and imbricate it. So a lot of surgical options are available once we go to the OT. We have the distal procedures like AKIN procedure, we have the Keller's resection, arthroplasty, we have the distal chevron osteotomy, we have the scarf osteotomy in the shaft, we have the concentric osteotomy and Lugloss osteotomy, we have the LAPIDUS fusion here, and the other osteotomies. So the basic treatment for hallux valgus depends upon the congruency of the joint, whether the joint is congruent or non-congruent, or whether there is any degenerative joint disease. If the patient's X-ray looks something like this, where you can see that the metatarsophalangeal joint is arthritic, it is better to do a fusion of the metatarsophalangeal joint. You can also do prosthesis, but the results of these prosthesis are not that promising as compared to arthrodesis of the joint. So if the joint is congruent, we have a lot of options that we have With us, that will be a distal metatarsal osteotomy and AKIN's procedure, double, triple, first ray osteotomy. We can also do a scarf osteotomy and a minimal invasive osteotomy. So if the joint is incongruent, then we have something like this. So your books write a lot of stuff regarding the treatment of incongruent joint. This becomes very confusing and very difficult to remember. So as an orthopedic surgeon or a postgraduate, you tend to um, be very upset with this flow chart for the management of hallux valgus. So we need to simplify it. The Coughlin and Robinson tried to simplify it regarding the treatment. So I am going to tell about that. So a very simple way of learning how to manage a mild case of hallux valgus, that is a case where the hallux valgus angle is less than 30 degrees and the intermetatarsal angle is less than 13 degrees, is by doing a distal soft tissue procedure with a distal osteotomy like a chevron osteotomy. So in short, in a mild hallux valgus case, you can do a chevron osteotomy. In case of a moderate hallux valgus, where the hallux valgus angle is between 30 to 40 degrees and the intermetatarsal angle is between 14 to 20 degrees, we need to do a more powerful osteotomy like that of a proximal shaft osteotomy or a scarf osteotomy that is very commonly done and popularly done all over the world. In case of a severe hallux valgus, where the hallux valgus angle is more than 40 and the intermetatarsal angle is more than 20 degrees, we have to do a more basal osteotomy or a lapidus fusion. This lapidus fusion is very popular in the United States, where we do fusion of the first metatarsal and the medial cuneiform. So if at all you are not able to understand anything from my presentation, this would be my most important slide of the presentation. Remember one thing in this presentation, that you do surgery only in patients who are symptomatic, and the surgery should not be done for cosmetic reasons alone. So soft tissue procedures, they were initially done, but it has been associated with a dissatisfaction rate of 41% cases. So it's a big no-no. It should never be done alone. It should always be done with the bony procedures. So remember the 4 questions that we asked. What is, if there is any metatarsal joint arthritis? The answer is simple: fuse the metatarsal joint arthritis. Fuse the metatarsophalangeal joint. The next question that we had asked is that, is there any hypermobility of the first ray? Yes, if the root test is positive, what we can do is fusion, the lapidus fusion. So the third question that we asked is whether the MTP joint is congruent. If it is congruent, well and good, we can do the bone osteotomies and correct the angles. If the joint is not congruent, we have to add the distal soft tissue release procedures. And depending upon the severity, we discussed that the mild hallux valgus, we do a chevron, a moderate scarf, and for severe we do TMT fusion or a lapidus procedure. The chevron osteotomy is generally recommended for patients of mild hallux valgus in the age group patients who are less than 50 years, with the angles normally in the mild range. The advantages of a chevron osteotomy over a Mitchell osteotomy is that the location is in the cancellous bone, and it causes less shortening of the metatarsal as compared to the Mitchells, and it is more and inherently a stable osteotomy. So this is how we do a chevron osteotomy. A medial incision is made, and after that thick flaps are raised of the capsule dorsally and plantarly, and we expose the metatarsal head and do the soft tissue release. And this is a removal of the medial eminence with a power saw. Then, after the medial eminence has been removed, we do a chevron osteotomy with apex distally. So this apex of the chevron is around 1 to 1.3 centimeters from the tip of the metatarsal head, the articular surface, and the two limbs are of equal length and they are at an angle of 30 degrees with the long axis of the metatarsal. The total angle between the two limbs would be around 60 degrees. So once the the osteotomy is complete, the proximal fragment is held with a towel clip and it is pulled medially, while as the distal fragment is pushed laterally with a thumb. So once we do that, the amount of translation that is allowed is around 4 to 5 mm. That is 40 to 50% of the width of the metatarsal bone. And once the translation is done, the distal fragment is pushed laterally and the proximal fragment is pulled medially. Once the translation is done, it is secured with K-wires and you can put screws in the osteotomy site. So the other very popular osteotomy is the scarf osteotomy that we do in the shaft of the first metatarsal, and it is done for moderate hallux valgus. It is one of the most versatile Z osteotomies that allows multiplanar correction. This is something that we have learned from carpenters, and it allows translation, angulation, and depression of the metatarsal head. This osteotomy has a very long learning curve and need to do a lot of do and see a lot of scarf osteotomy before we carry out the osteotomy. So here is how we do the scarf osteotomy. This is the long limb of the Z. This will be the two short limbs of the Z osteotomy or the Z osteotomy. This will be the dorsal distal, and this will be proximal plantar. So this would be the dorsal distal would be around 5 mm from the joint surface, and the depth would be around 3 mm. The angle of the Z osteotomy would be around 60 degrees, and this long limb of the Z axis should be parallel to the ground line, and the two short limbs of the Z osteotomy need to be parallel to each other. So this is how we do scarf osteotomy. First of all, the medial eminence is removed with a power saw, and then you put two K-wires at the corner ends of the proposed osteotomy site. These K-wires have to be placed perfectly. They need to be put perpendicular to the long axis of the first metatarsal, and also these K-wires should be parallel to the plantar surface of the first metatarsal. So after that, we take the cuts. First cut is made is the distal dorsal, and then we make the long limb. We take the cut for the long limb of the Z osteotomy or the Z osteotomy, and then we go proximal plantar. So this is what we do. The plantar capitellar fragment after the osteotomy is complete is pushed laterally, thereby correcting the hallux valgus angle, the intermetatarsal angle, and the distal metatarsal articular angle. The dorsal proximal fragment is pulled medially, and once we do that, we fix it initially with K-wires, and then they are replaced with screws, and two screws are put on the osteotomy site. And then, because of pulling of the dorsal proximal fragment medially, we have an extra edge of medially we have an extra bone that has to be cut, and that they can also be used as a graft. So this is a patient with with the hallux valgus, the preoperative photographs, and here we have done a scarf osteotomy, and we also have added an AKIN osteotomy to it. So what is an AKIN osteotomy? AKIN osteotomy is nothing but a medial closing wedge osteotomy in the proximal phalanx. It is done to correct the interphalangeus, hallux interphalangeus, and also pronation of the great toe. It also corrects the pull of EHL and FHL. So the LAPIDUS procedure, which is the fusion of the first metatarsal medial cuneiform joint, it is done in severe cases of hallux valgus, where the hallux valgus angle is more than 40, intermetatarsal angle is more than 20. In cases of metatarsus primus virus, that is a very important cause of hallux valgus in adolescents, and if the first tarsometatarsal joint is hypermobile, that we can do by doing the root test. So Keller's resection arthroplasty is something that we don't do, right? We have largely abandoned, stopped doing it. Here what we do is we remove the medial eminence, and also we resect the base of the proximal phalanx. This procedure can be reserved to be done in elderly patients with low functional demands. So this is the new kid on the block. This is minimal invasive osteotomy. How do we do it? Is that we pass a 2 mm K-wire medial to the hallux extra periosteally and put the K-wire somewhere here, and then we do a percutaneous osteotomy at the metaphyseal-diphyseal junction. And once the osteotomy is complete, the distal fragment is pushed laterally, and the K-wire is then pushed into the intramedullary canal in the proximal fragment. And once this heals, the patient improves with the hallux valgus, as we can see here in this X-ray. So this is something that we need to be worried about, of too much of correction, too much of release laterally, and more of capsulorrhaphy on the medial side can lead to hallux varus. And this is a dreadful complication that we need to be that we need to take care to avoid making the hallux varus, because this patient will not be able to wear any sort of shoe. So in short, the things that we need to remember while doing any surgery would be that whatever the procedure that we take should be easy and reproducible. The osteotomy that we do should be stable. It is important that the length of the first metatarsal is always maintained, and the osteotomy that we do should be versatile, so that all the angles that we have discussed can be corrected by it. We have to preserve the metatarsal blood supply in order to avoid avascular necrosis of the metatarsal head. And lastly, the long-term outcome should be such that it has a very low recurrence rate of the deformity. I hope you enjoyed the presentation. Any queries you can put in the comment section. Thank you very much for listening.